So here we're going to discuss osteogenesis imperfecta. Now, on the test, I would expect that a question on osteogenesis imperfecta is going to be pretty straightforward. However, I want to give you sort of a better view into what this disease is, so that it might help you distinguish this from some of the other disorders that can be difficult sometimes in a clinical scenario. So we'll just briefly go over what this is. We'll talk about the genetics behind it, which is somewhat complicated, how this is classified, the features that show up in the various forms of OI, how these children develop briefly, then how you can go about working this up and making the diagnosis, and then finally we'll talk about the management. So OI is a heritable generalized disorder of connective tissue. Namely, here we're talking about type 1 collagen, and as you probably know, type 1 collagen makes up a very important part of our bones. So it follows logically that a disorder of type 1 collagen is going to affect our bones and our bone strength and what have you. This encompasses a range of disorders which vary in phenotype and genotype, and you can't necessarily look at the genetic mutation and necessarily know exactly how the patient is going to manifest. And so it's for that reason that primarily this is a clinical diagnosis as opposed to something like maybe Down syndrome or Fragile X syndrome, where you can really look at the mutation or look at the genetic abnormality and say, I know how this patient is going to present. The classic triad of osteogenesis imperfecta, and primarily here we're talking about type 1 osteogenesis imperfecta, is the triad of fragile bones, blue sclera, and early deafness. Now, to what extent you're going to see this is going to vary, but in type 1, the classic osteogenesis imperfecta, the kind of osteogenesis imperfecta that the USMLE is probably going to ask you about, you're going to see these three things. This is the most common genetic cause of osteoporosis. Remember, osteoporosis being a very, very common manifestation. Typically, we see that in older people. We don't see that in young people. And so when we see young people with defect of the bones, osteogenesis imperfecta, when it's fragility of the bones, OI is on our short list of differential. Classically, OI has been associated with a defect to the genes encoding the type 1 collagen chains. Those genes would be COL1A1 and COL1A2, which are respectively on the long arm of chromosome 17 and the long arm of chromosome 7. But now we know that there are several other genes involved. However, 80% of cases are due to defects of these genes, COL1A1 and 2. 90% of cases are autosomal dominant in inheritance. And then this affects about 1 in 20,000 infants, and there is some geographic variability. In Eastern Africa, there is a carrier rate of about 1 in 200, 300. I think this sample is from Kenya, would be East Africa. All right, so I want you to know type 1 and type 2. If you know type 1 and type 2, you're probably good for the test. But as far as knowing what osteogenesis imperfecta is and the various ways that this can present, and certainly in children that you may come across, there are other types. So osteogenesis imperfecta type 1 is your classic OI that you'll see in children because these children live, as opposed to type 2, for instance. So this is the mildest form of OI, and this is associated with that classic triad of breakable bones, blue sclera, if you really look, and then also the presenile hearing loss. Some other connective tissue abnormalities can include easy bruising, joint laxity, and then they can also have translucent teeth, and this is called dentinogenesis imperfecta. And sometimes when you see osteogenesis imperfecta classified, you'll see it classified as 1A, 1B, 2 or 3A, 3B, 5A, 5B, And what the A means is if there's no Dentinogenesis Imperfecta, and then it's B if there is. And we'll look at what Dentinogenesis Imperfecta is later on. But Dentinogenesis Imperfecta, in short, means that your teeth are going to be brittle as well. Of course, they can have otosclerosis as well, and that's what leads to the hearing issues. Fractures will decrease with puberty. Typically with OI type 1, the fractures are going to really start to manifest when the child becomes mobile and starts walking. And as you know, anytime a child starts walking, there's going to invariably be falling, and that's typically when these fractures manifest. However, they can manifest early if parents not holding the baby right, or if this is just a more severe form of type 1. So we're running a gamut here. Not all patients with the same diagnosis are going to have the same severity. Now, on the other hand, Osteogenesis Imperfecta type 2 is a perinatal lethal variant. So these babies do not survive typically past the first year of life. Usually, though, they're stillborn. They'll die in utero. When they're born, they tend to have a low birth weight. They certainly have a low length. And their head, because it develops relatively normal compared to the long bones, that head is going to appear large for body size. But there's really nothing so much wrong with that head. It's the long bones that are defective. And enlarged fontanelles can be noted as well. This can be picked up on by prenatal sonography. A level 2 sonography can usually demonstrate multiple uterine fractures of long bones, which will appear crumpled. And when the baby is born, be it stillborn or not, because of the breaks in the bones, the legs will typically be held in a frog-leg position. However, if there's breaks in bones to those long bones, the legs can be held in frog-leg position really in any osteogenesis imperfecta. So that's not necessarily a specific sign. A lot of times there's rib fractures because the ribs are prominent and typically exposed, even in utero, and so those rib fractures can give a beaded appearance. And a small thorax leads to respiratory insufficiency, and that will usually be the cause of death in these babies if they do survive outside the womb. Osteogenesis imperfecta type 3 is a progressive deformity. This is the most severe non-lethal form of OI. So we talked about type 1, that's your mild OI, most mild. And type 2, which is lethal. Type 3 you can live with, but it's the most severe form of OI that you can live with. And this leads to significant physical disability. Usually there'll be fractures in utero, which will manifest after the baby is born, which you'll see. There'll be relative macrocephaly, just due to the shortened limbs. A triangular facies can be noted due to malar hypoplasia. You may note a pectus deformity, asymmetric ribs, or asymmetric chest. Usually they'll go on to develop severe scoliosis, vertebral compression, and they'll often be very, very short. An X-ray of the bones will often show a popcorn appearance at the metaphyses. OI type 4 is moderately severe, and this would be something like between type 3 and type 1. And this can present at birth with intrauterine fractures as well as bowing of the lower long bones, or it can present at the beginning of ambulation, more similar to the type 1 OI, with frequent fractures on bowing. And this will require orthopedic and physical therapy intervention, but typically these children will be able to attain community ambulation, and they will tend to be moderately short, and the fractures will decrease with puberty. Osteogenesis imperfecta type 5 is a hyperplastic talus variant. It looks just like type 4, but when these children have fractures, they tend to develop these hyperplastic calluses. And you can also see a metaphyseal band on X-ray. Type 6 is a mineralization defect. Otherwise, it looks like type 4. This is autosomal recessive in inheritance. And then type 7 and type 8 are also autosomal recessive and inheritance. These are moderately deforming. They feature rhizomelic shortening of the humerus and femur. The sclera tend to be normal and white, and there's never any Untitled Imperfecta with 7 and 8. So mostly I included types 3 through 8 for your information. Types 1 and 2 are going to be the ones that you're most responsible for knowing on USMLE. That if a child has OI type 1, they have that triad of features. That's type 1. If they're stillborn and they have these features, particularly that they're born with fractured bones, that's type 2. So here's a baby born in frog-leg position, or holding their legs in a frog-leg position, and this is due to fractures of the long bones, particularly the femur. Now this baby we don't know. Do they have type 2, type 3? What is it? We don't know, just based on this alone, but that's what that frog-leg posture means. Now this happens to be a baby with type 2 Osteogenesis Imperfecta, and this is a baby that passed away. But what I want you to note here is the relatively large head and the relatively short limbs. This child likely has type 3 OI, and what you will note here are the blue sclera, the malar hypoplasia. This child has a pectus deformity and also an asymmetric chest and some flaring of the chest at the inferior margin. So this is an example of blue sclera. Like you see blue sclera in other things. You can see it in Ehlers-Danlos syndrome, but blue sclera is something that you will see in OI, a classic sign of OI. So here's an even more obvious blue sclera. Now looking at X-ray, this is OI in, it's hard to tell, looks like a humerus. And what you note here is that there's significant osteoporosis. And that's something that you'll see in OI, and there's also bowing of this arm. So this arm is, this shouldn't be curved like this. And this just has to do with the fact that there is collagen defect in this bone, and so it's not as strong as it should be. So here's another example of that bowing and the osteoporosis within the bone. Now this is a type 3 OI, and I can't really tell what the X-ray is here. It looks like it might be a femur. But what you note here on this tibia is that popcorn calcification right here. And you also can pick out some, it probably looks like a fracture right here. So this is popcorn calcification. And here's another example of that right there. Another feature that you can see, and this can be completely normal as well, but you see this wormian bones. And the wormian bones is just a feature that you see on skull X-ray where the skull bones are coming together. And that's right here. Here I got a better picture. See it down here. So this can be a feature that you see on skull X-ray and OI. So this is appears to be a normal child in comparison to a child with Osteogenesis Imperfecta. Note the scoliosis here. Here you have scoliosis again. This S-shaped scoliosis is something that you'll see as a complication as these children develop. Now here, these bones look relatively normal with the exception of the bowing at the femur. But what is interesting here are these little lines, we call these zebra lines, and these aren't actually due to the Osteogenesis Imperfecta. This is actually caused from the treatment for OI. A lot of times we give these children bisphosphonates to help with their bone mineralization, and that causes these lines. So more bone. So this is an example of how patients with type 1, type 4, type 3 will look. You can see that type 1 typically appears relatively normal. You can see that this female here is 171 centimeters. I don't work in centimeters, so what is that in inches? It's like, probably like 70 inches, give or take. So this would be like a 5'10" female. That's pretty tall, right? Now, on the other hand, where you have type 3, you have that's the most severely affected that you can live with. You see significant bowing of the limbs, severe scoliosis in this male patient here. And these patients, this is a 40-year-old male who's only 84 centimeters tall. So that's only 3.5 feet tall or so, 3 feet tall. This is Dentinogenesis Imperfecta, and so with Dentinogenesis Imperfecta, it can look different depending on the patient, I guess, but you see translucent teeth. Now, these teeth aren't as translucent as some of the other ones that I have to show you, but you can definitely see that there's a defect of the teeth. These teeth aren't as bony white as they should be, and that makes sense because this is a disorder of bone. So here you can see it's a little bit more translucent here, and definitely in this one here. Very translucent. You can almost see through that bone, or that tooth. You can't see through it like a window, but it does have some, as you can see, translucent properties to it. Okay, hopefully you're getting the idea of this one. This one's these are very translucent teeth. So lots of translucency. See, these almost look like sort of like pearly, almost like, I don't know what that stuff is that's got that clear look to it. It almost appears sort of porcelain-like. This is very mild Dentinogenesis Imperfecta, and you look here, you can see it sort of along the gum line. Now, as far as the development of these children, really we're only thinking about their physical development. So it's going to depend on the type and the severity, but mild forms will develop usually pretty normally, despite the fact that they have a predisposition for fractures. And so that may be a cause for them to be in and out of the ED. Scapular fracture or clavicular fracture, fracture of the femur, places where you're able to fall very easily. Types 3, 4, and 5 typically will require some degree of mobility assistance, but particularly with type 4, they tend to be able to do a little bit better with assistance later on. Okay, so for diagnosis, not all the mutations in OI are necessarily known, so typically you have to rely on clinical diagnosis. The presence of a blue sclera is highly suggestive, but not pathognomonic for OI because it can be present in other symptoms, like Ehlers-Danlos syndrome. And when you add that on to the fact that children with type 1 OI can also have stretchy skin and hypermobile joints. You can see how you can get into a little bit of a conundrum here. What you want to look for is this classic triad, first of all, so frequent fractures, not something that you're going to see necessarily in Ehlers-Danlos syndrome, blue sclera, and then reduced hearing. Translucent teeth is a very specific sign for osteogenesis imperfecta if it's in conjunction with issues with fractures and hearing. And then, of course, a family history. Remember that most of these are autosomal dominant, and of cases that you will see clinically, it's over 90%. So you should have some level of family history if you elicit it. differential diagnosis includes idiopathic autosomal recessive hyperphosphatemia. This is also called juvenile Paget's disease. This shares bone demineralization properties, but this is due to increased bone turnover and high serum alpha phos activity. And so what you can do very easily to get a differential from this is to include in your workup an alkaline phosphatase level. And in juvenile Paget's disease, the alkaline phosphatase level will be very high, whereas in osteogenesis imperfecta it will not be. Hypophosphatasia is a variable presentation. This tends to be low bone alkaline phosphatase activity. So this is hyper and hypophosphatasia, not hypophosphatemia. So I kind of mix those up a little bit. But phosphatasia means phosphatase levels, whereas phosphatemia means phosphates in the blood, TO14 minus. Okay, idiopathic juvenile osteoporosis is a little bit easier to tease out because, one, this is non-hereditary, two, there's no extraskeletal involvement, and three, this tends to develop in children who were previously well. So this is usually in an 8 or a 9-year-old, and they didn't have any problems before then. They didn't have any issues with their bones breaking or anything like that. So whereas osteogenesis imperfecta, you have it from birth. Big one on the USMLE that they'll love to ask you about is it osteogenesis imperfecta or is it child abuse? There are a lot of things in common as far as how they present. What do we look for when we look for child abuse? We look for injuries, particularly injuries in various stages of healing, because little Johnny got kicked in the face by mom 2 weeks ago, and then kicked in the gut by dad yesterday, and I got scalded with the iron by mom last week, and so he's going to have injuries in various states of healing. And that's going to happen with osteogenesis imperfecta because you are prone to fractures. You're going to have fractures in various stages of healing as well. And when you hear the story, if you don't know that the child has osteogenesis imperfecta, it might be hard to believe. Kid fell off the bed onto the hardwood floor, now has a hairline fracture of the femur. Or kid fell off the swing, has 3 rib injuries, 3 rib fractures. You wouldn't think of that in healthy children. And so your mind might go off right again then to child abuse because the story doesn't meet the presentation. However, if you have a disease that affects the stability of your bones, then that trivial injury certainly can cause those kinds of features, that severity of bone breakage, and that can be alarming. So one of the best ways, if you really are hung up and you don't know is this OI or child abuse, is to get a bone mineral density test. That will tend to be abnormal in OI, but not always. And that can be useful for differentiating from abuse. But the story is usually helpful. Get a look at the family history, the family dynamics. A lot of that will help in real life. But you really just have to use your clinical judgment with this. So, of course, also look for other things, hearing loss, food sclera, stuff like that can help you too. So you'll get a workup when you suggest OI. You should get a basic metabolic panel. Also get a serum calcium level. You get an alkaline phosphatase to differentiate from the hyperphosphatasia. Get a vitamin D level because we're always concerned about nutritional issues. Get a parathyroid hormone level, and then a skeletal survey. And you can also get gel electrophoresis using cultured dermal fibroblasts. And that will be useful to look for the types of collagen that are present. And with osteogenesis imperfecta, type 1 in particular, you'll have a decreased ratio of type 1 collagen to type 3 collagen. You can also see in types 1, 2, 3, 4, 7, and 8, you can see over-modified collagen on gel electrophoresis. Now, this has been associated with some false positives, but for the test, this is a pretty good exam to get if you need to as part of your workup if the clinical picture isn't obvious. DNA sequencing can be useful for establishing the exact mutation as far as counseling these patients genetically. Multidisciplinary management is going to be warranted in these patients. So, of course, our number one concern is making sure that these patients are safe and that we can get them to be mobile. Because if they aren't mobile, especially if they already have an injury and they don't mobilize that injury when it's appropriate, you can develop contractures, and especially when we're talking about children who are already supposed to be growing, that can open a can of worms. So we want them mobile as much as possible. We can set them up with physical therapy, occupational therapy, and orthopedic management with the goal of attaining maximal functional mobility. Children with type 3 and 4 will usually benefit from gait aids, swimming and conditioning programs, low-stress activities. Severely affected patients, namely those with type 3, will in many cases require a wheelchair. We want to ensure adequate vitamin D and calcium in their diet and monitor their vitamin D and parathyroid hormone levels regularly. It's been recommended that they get annual DEXA and spine films, particularly as they get a little bit older towards puberty when that risk of scoliosis starts to go up. It's been recommended that you try a course of bisphosphonates. Usually this will be done by a specialist. Usually IV bisphosphonates are preferred, and you just need to weigh the benefits of increased bone volume and reduction in vertebral compression. One study has shown a 50% reduction in fracture, and also the subjective reduction of bone pain. This helps these patients a lot of times with their bone pain. To the risks of interfering with appropriate material properties, longer use of bisphosphonates can be associated with non-union after fracture, abnormal remodeling, and can also interfere with the attainment of their adult height. So this, again, done by a specialist. It's optional in many cases, but this is something that's often done, as evidenced by that x-ray that you saw with those zebra stripes. And then providing education to the parent and age-appropriate education to the patient. Long-term, adults are going to need continued physical and occupational therapy as well as caution for their increased risk of fracture. One of the big problems coming out of this that you see most often is repeated respiratory infections, and that can result in pneumonia, and this presents the most severe non-bone-related complication for these patients. Other complications include brainstem compression, which is pretty rare with the exception of the very, very severe cases, and hydrocephalus. This is due to basilar compression. Neurologic symptoms should be followed up with a neurologist and appropriate imaging to diagnose the same. Types 1 and type 4 are associated with a normal lifespan. Type 3, type 6, and type 7 are slightly reduced to